Hello everyone. As a part of continuous cardiac education, our topic of discussion today is approach to broad complex tachycardia, which will be presented by Dr. Shomu Bora sir, who is Associate Professor in Cardiology Department at UN Mehta Hospital and having more than 15 years of experience in the field of interventional cardiology and electrophysiology. Looking forward to your kind presence. Thank you.
A very good day. I am Dr. Shomu Bora from UN Mehta Institute of Cardiology and Research Center, Ahmedabad. Today I will be talking on approach to broad QRS tachycardia. So why are we discussing this topic? It is very important in clinical cardiology to diagnose and treat appropriately a broad complex tachycardia, which is generally a ventricular tachycardia, and often urgent therapy is required for these patients as they become unstable at the onset or deteriorate rapidly at any time. Therapeutic decisions are further complicated by the risk associated with giving therapy for a SVT to a patient who actually has a ventricular tachycardia. A broad complex tachycardia is generally considered to be a ventricular tachycardia which is associated with risk, and therefore it is important to diagnose ventricular tachycardia, and broad complex tachycardia basically serves a purpose to diagnose ventricular tachycardia. So, overview of the topic, we will be discussing definition, causes, how to differentiate VT versus SVT on ECG, and how do you approach a regular broad complex tachycardia, going on to irregular broad complex tachycardia, and then pacemaker mediated tachycardias. So when do we say it is a broad complex tachycardia? If the QRS duration is more than 120 milliseconds in an adult, it is considered to be a wide QRS tachycardia. So when do we have a wide QRS rhythm? It can be for any tachycardia which arises below the His-Purkinje system, or even if it arises above the His-Purkinje system, when it conducts with aberrancy, it can have a broad complex rhythm. So a narrow complex is only possible if the impulse arises from above the AV node and the His-Purkinje system and conducts normally through the conduction system. While a broad complex rhythm can be because of various causes. It can be because of SVT with aberrancy, either RBBB or LBBB, and there results in myocardial conduction resulting in a broad complex. It can be because of conduction via an accessory pathway antigradally resulting in myocardial conduction and therefore causing broad complex tachycardia. A myocardial VT can cause broad complex, or a bundle branch reentrant VT can cause a broad complex tachycardia. Additionally, pacing through a pacing wire position in the right ventricle or the left ventricle causes broad complex. So what is the cause? What are the causes of broad complex tachycardia? Ventricular tachycardia most commonly because of structural heart disease, which is car related, most common because of ischemic heart disease, cardiomyopathies, and others, myocarditis. Bundle branch reentrant VT can also be a cause of a ventricular tachycardia, though uncommonly seen. Idiopathic causes like outflow tract tachycardias and fascicular tachycardias are not uncommonly seen, and polymorphic ventricular tachycardia related to channelopathies or drug toxicities or ischemia itself are seen as a cause of wide complex tachycardia. Supraventricular tachycardias can present with aberrancy in patients with pre-existing bundle branch block or can be related to a rate-related bundle branch block. It can be also because of drugs like antiarrhythmic drugs 1A, C or 3. It can be because of electrolyte disturbance, especially hyperkalemia. Other supraventricular tachycardia resulting in an antidromic tachycardia like a Mahin fiber tachycardia or a WPW with antidromic tachycardia are causes of wide complex tachycardia. Lastly, pacemaker related rhythms can cause wide complex tachycardias. So nomenclature wise, non-sustained tachycardia is a 3 or more beats in duration at a rate of more than 100 per minute, which can be of a single morphology, that is called a monomorphic ventricular tachycardia, or it can be of polymorphic morphologies It is called a polymorphic ventricular tachycardia. It is said to be sustained when it lasts for more than 30-second duration, or it requires termination due to hemodynamic compromise in less than 30 seconds. Bundle branch reentrant VT is due to re-entry involving the His-Purkinje system, and usually it is LBBB in morphology, generally occurs in settings of cardiomyopathies. Bidirectional VT is a beat-to-beat alternance in the QRS frontal plane axis, which is associated often with digitalis toxicity or CPVT. Torsade points, which is characterized by a long QT and a twisting of the peaks of the QRS complex along the isoelectric line in the arrhythmia. It is typical or atypical in nature. Ventricular flutter is a regular monomorphic appearance, very fast at a cycle length of 200 millisecond, and ventricular fibrillation is a very fast rhythm, irregular at a cycle length of more than 180, so less than 180 milliseconds. So how do you differentiate on ECG a SVT versus a ventricular tachycardia? The differentiation features are based on primarily the P waves and the QRS relationship. So in SVT with aberrancy, the atrial activity is equal to ventricular activity, or atrial activity is more than ventricular activity. Rarely it can be less, and can be seen in AVNRTs or 1 to 2 conduction. Ventricular tachycardia is characterized by ventricular activity more than atrial activity, or it can be equal. In patients who have associated atrial fibrillation or atrial flutter, the atrial activity may be more than ventricular activity, however they may be dissociated, so there may not be any association. Now, what do we see in this relationship? So the first is AV dissociation. AV dissociation is uncommon in patients with SVT with aberrancy and commonly seen with ventricular tachycardia. Fusion beat and capture beats are seen with ventricular tachycardias. The second major point of differentiation is the QRS morphology. So you have a typical morphology of right bundle branch block or a left bundle branch block in SVT with aberrancy, while you may have typical as well as atypical morphology in patients who have a ventricular tachycardia. The third difference would be in QRS axis. There has to be a significant change in axis in ventricular tachycardia, and northwest axis, that is extreme axis, is seen in ventricular tachycardia. Generally, the QRS axis change is not more than 40 degrees in patients with SVT with aberrancy. A QRS duration is generally less than 160 millisecond in SVT with aberrancy, except that in patients who are taking medications. A QRS duration of more than 160 milliseconds generally suggested to be a ventricular tachycardia. A concordance in chest leads, either positive or negative concordance, is unlikely to be seen with SVT with aberrancy and suggests generally a ventricular tachycardia. A highly irregular tachycardia is either atrial fibrillation in SVT with aberrancy or a polymorphic torsades or ventricular fibrillation in ventricular tachycardia. If you have an onset documentation, a ventricular tachycardia starts with a QRS complex. You may have additional points in which in sinus ECG you may have pre-excitation or atrial enlargement in SVT with aberrancy, while in ventricular tachycardia you may have additional Q waves, low voltage complexes or high voltage complexes, poor R wave progression or intraventricular conduction defect. So coming on to individual points, the most important point for a differentiation between ventricular tachycardia and SVT is that there is a dissociation between the QRS complexes and the P wave. If P waves are evident and you see a dissociation, it is diagnostic for ventricular tachycardia. If P waves are not evident, then you can have direct recordings from the atrial chamber like an intracardiac catheter, or have an esophageal lead also which can show the dissociation. So this ECG shows a broad complex, regular tachycardia, and if you see in lead V1, you can see the P waves which are dissociated from the QRS complex. The QRS complex are more than the P waves, and you can see that there is a P wave which is coming lesser than the QRS. So it is clearly that you have more ventricular activity as compared to atrial activity, and therefore has to be a ventricular tachycardia. Occasionally in a broad complex tachycardia, if you see a ventricular to atrial relationship 1:1, as you can see in V1 here, you may do certain maneuvers like carotid sinus massage, and clearly you can see that there is a drop in the atrial activity. So the atrium activity is lesser than the QRS again, and this suggests it's a ventricular tachycardia. Subtle non-rate related fluctuations can be there, as in variations on the QRS morphology or the T wave, if you can see here, and they may reflect variations either in the VT reentrant circuit within the myocardium, or it can be because of the presence of P waves on the QRS or the STT segment. Generally, SVT is characterized by uniformity of the QRS and the STT shape unless there are rate changes. So as you see here, even in a ventricular tachycardia, 1:1 conduction is seen here. It's a slow ventricular tachycardia, and this bump is suggestive of a retrograde activation of the atrium. So it is positive in V1 and negative in 2,3 AVF, suggesting it to be a ventricular tachycardia. The second most important finding in AV dissociation would be fusion and capture beats. So what are fusion beats? It is a beat which is of a morphology in between that of a sinus beat and a ventricular tachycardia beat, that is fused. It is narrowish, it comes early as compared to the expected QRS of the ventricular tachycardia. What is a capture beat? It is basically a QRS morphology mimicking a sinus beat which comes during the tachycardia early enough because of antegrade activation via the His-Purkinje system due to a conducted P wave. So this confirms the diagnosis of a ventricular tachycardia generally. Again, an example of a capture beat regularly occurring. These are also called Dressler's beats, and this is when there is a normal antegrade conduction via the AV node. You may find this kind of ECG where you have all of the findings of P being less than the QRS, showing dissociation. You may have a capture beat as well as a fusion beat, and this suggests this tachycardia to be a ventricular tachycardia. Going on to the next major differentiation, how to differentiate between an SVT and a ventricular tachycardia, is QRS morphology. So normally you have narrow complexes, while if you have bundle branch block in an SVT, in V1 you have either an RS complex, and in V6 with LBBB you have a R wave. In RBBB in SVT there is an RS R dash complex. The R dash is taller than the initial R in V1. In RBBB you have a Q, R and S wave in V6. So this is normally seen with SVT, and this is typical bundle branch block pattern. While in ventricular tachycardia you may have a typical bundle branch block pattern, especially in bundle branch reentrant VTs. However, most of the SCAR VTs will demonstrate a atypical bundle branch block pattern. In RBBB, it is characterized by an initial R that is taller than the later R, or a monophasic R pattern in V1. Similarly, in V6, there may be a QS pattern in RBBB, which suggests that this is likely to be a ventricular rhythm. In LBBB, if you have a QS pattern in V1 or a very small R which is broad, suggests a ventricular rhythm. In V6, absence of So presence of Q waves in a presence of a wide complex tachycardia should suspect a presence of a ventricular tachycardia. So diagnosis of ventricular tachycardia based on morphology: in V1, if you have a single peak, initial taller rabbit ear, or a QR pattern, or a RS, which is initial R is very broad, suggests to be a ventricular tachycardia. In V6, if you have a QS pattern or a QR pattern, then it generally suggests to be a ventricular tachycardia. In aberrancy, you have a RSR dash in V1 or a QR pattern in V6, which is suggestive of a SVT with aberrancy. The second part in QRS morphology, especially in chest leads, would be an initial R which is slurred and delayed, which is more than 30 milliseconds, as you can see in this figure, or from the start to the nadir of the S wave, a duration of more than 100 milliseconds, or a notch in between. All three would suggest that this is likely to be a ventricular tachycardia. So here, if you see a QRBBB pattern in V1, and additionally you are seeing changes in the STT segment suggesting AV dissociation, suggests likely to be a ventricular arrhythmia. A QRS morphology which changes differently. So SVT with aberrancy would have either RBBB or LBBB, but if you have multiple morphologies, broad complex rhythm in a patient, it is likely to be a ventricular tachycardia. What about the QRS axis? A northwest axis, that is an initial R in AVR, or a change in axis of more than 40 degrees from the pre-existing, or right bundle branch block with left axis deviation, or a left bundle branch block with right axis deviation, all suggest it to be a ventricular tachycardia. So if you have a broad complex regular tachycardia, and if you have a northwest axis, that AVR is only positive, rest are all negative, and the patient has a broad complex regular tachycardia, it is likely to be a VT. So the next important differentiation is by QRS duration. If a QRS duration is more than 160 millisecond, it is a strong predictor for ventricular tachycardia. Exceptions being WPW antegrade pre-excitation or patient being on type 1 antiarrhythmic drugs. In RBBB, even a QRS duration of 150 millisecond is significant enough. So in this ECG, it shows a RBBB with QRS duration of more than 200 milliseconds, suggesting that it is likely to be a VT, with additional features being initial R being more taller than the later R, and this suggests likely to be a ventricular tachycardia. In a LBBB morphology, the QRS complex being more than 200 millisecond here, with additional features of likely AV dissociation, suggests this to be a ventricular tachycardia. Sometimes you may have a QRS duration which is just borderline 120 milliseconds, and in that you have to differentiate whether this is a narrow complex or a broad complex tachycardia, and the presence of an atypical RBBB like this, QR complexes in V1, would suggest that this patient is likely to have a ventricular tachycardia. It is not very uncommon to see a narrow complex tachycardia but with clear AV dissociation, which is suggesting this narrow complex tachycardia to be a ventricular tachycardia, and it carries the same grave prognosis as a broad complex tachycardia that in a patient with structural heart disease. So a narrow complex tachycardia being a VT is definitely more dangerous as compared to just a broad complex tachycardia in a normal heart. And if you have a baseline QRS which is broad and a tachycardia QRS which is narrower, it suggests that this tachycardia was a ventricular tachycardia. The next differentiation would be on concordance. So concordance is present when QRS complexes in all 6 precordial leads, that is V1, 2, V6, are monophasic with the same polarity. The presence of concordance suggests that this tachycardia, broad complex tachycardia would be a ventricular tachycardia with 90% specificity, but sensitivity is low. Negative concordance is more specific. So if you have a negative concordance V1 to V6, then it is likely to be a ventricular tachycardia. A positive concordance pattern in V1 to V6, all being R waves, suggests more likelihood of a ventricular tachycardia. However, it can still be a antidromic WPW pre-excitation. A regular tachycardia, generally ventricular monomorphic tachycardia is regular. Slight variation may be seen, generally which is less than 10 millisecond. A variation of more than one small square, that is more than 30 milliseconds, is very unusual, and 2 episodes of same VT with different cycle lengths are very rare. More marked irregularity in RR intervals occurs with polymorphic VT and atrial fibrillation. So if you have a very irregular tachycardia which is towards monomorphic, think of towards being of atrial fibrillation. So this is a wide complex tachycardia, and you can see the maximum RR interval being 10 here and minimum being 8. A difference is there. This is possible in ventricular tachycardia. If it is continuously changing, then think of atrial fibrillation with aberrancy. So as you can see here, the RR interval is changing rapidly, and there are areas where there is a narrow complex. Now this is not a capture beat because it is coming later than the initial tachycardia cycle length. Actually this is possibly a normal conducted beat, while these are aberrant because the initial R is very sharp in the conducted beat. So initial sharp, later slurred, likelihood of aberrancy. If you have a broad complex which is fast, very fast, with a smallest RR interval of less than 1 square, then it suggests it's likely to be AF with WPW. So in these, mostly all these have a monomorphic like pattern with changing in the width due to different degrees of pre-excitation. Onset of tachycardia may give you a clue if you are lucky enough to have it on ECG, and as you can see here, the tachycardia starts with the QRS complex without a preceding P wave, and the P wave comes later on, suggesting this to be a ventricular tachycardia. So how do you approach to differentiate ventricular tachycardia from SVT in a broad complex rhythm? The most important point is VT accounts for nearly 80% of cases in unselected population and more than 95% of cases in patients with prior myocardial infarction. So making a presumptive diagnosis of VT guards against inappropriate and potential dangerous therapies directed to an SVT, like giving calcium channel blockers or adenosine or beta blockers in a decompensated patients, which may precipitate a cardiac arrest. Treatment of SVT as if it were a VT is safe and frequently effective in restoring sinus rhythm. In presence of hemodynamic stability, it should not be regarded as a diagnostic feature of SVT, because VT, a slow monomorphic VT, can equally be stable. So in a broad complex rhythm, you should have a proper history, physical examination, see whether the patient is stable or unstable, and then get a 12-lead ECG and evaluate that ECG along with special maneuvers that will help you to differentiate. So historically, if you have a cardiac disease or a prior procedure or a family history suggestive for ventricular arrhythmia, think of it as a ventricular arrhythmia. Physical examination which suggests ventricular arrhythmia are changes in blood pressure, in a regular broad complex tachycardia, presence of Canon A waves intermittently and varying heart sounds, and cardiac decompensation features may be there. So it is important to see whether the patient is stable or unstable. Instability means lower blood pressure with a patient having low cardiac output, or patient going into pulmonary edema, or patient having chest pain. This may be related to the rate. This may be related to the heart status, including ejection fraction or presence or absence of structural heart disease. It can be associated with age or associated disease. In fact, coronary artery disease, ischemia, can decompensate a patient even in SVT. So if you have a patient with a broad complex rhythm and the patient is unstable, before cardioverting, rule out sinus tachycardia as in this patient, or rule out incessant tachycardia, a patient who has a starting and stopping tachycardia. Even if you cardiovert, it is going to start again. As in this example, before the patient was cardioverted, the patient went back into sinus rhythm. So it is important to rule out these two before you cardiovert in an unstable patient. So now if you have a stable patient, get a 12 lead ECG. A 12 lead ECG is important because it may show a same morphology in one single lead as in this rhythm while it is changing. So changing morphology is more likely to be a ventricular arrhythmia with a bidirectional change. Compare the ECG with a prior ECG. If you have a prior baseline ECG showing bundle branch block or evidence of structural heart disease or pre-excitation or ischemia, then it helps. Even a normal ECG would help, as we can compare it with the current ECG. But most of the patients will not bring a ECG and therefore it becomes an issue. So if you have a broad complex tachycardia and you are thinking whether this is a VT versus SVT or a sinus tachycardia, prior ECG would help, showing similar morphologies and therefore suggesting that that is likely to be sinus tachycardia or SVT with aberrancy. This patient who presented with broad complex tachycardia, RBBB with left axis, was being diagnosed as a ventricular arrhythmia, but if you see the rhythm strip here, you can see it is irregular in nature, and if you see the prior ECG, it is similar, RBBB left axis, suggesting this to be a SVT with aberrancy. So if you have a baseline ECG, it helps. Prior MI in this form of QRBBB, poor R-wave progression, suggests that this patient is likely to have a ventricular arrhythmia. A baseline ECG suggesting epsilon waves with frequent PVCs suggests that the broad complex rhythm would have been a ventricular arrhythmia, and baseline pre-excitation suggests likely that the patient would have WPW related arrhythmia if it is broad. Repeating an ECG if you are in doubt is very important. So in this patient, you have a broad complex rhythm, regular, with no P wave seen but no dissociation also seen, and diagnosis of SVT with aberrancy was kept. Repetition of ECG brought out the P waves, which was sinus-like, and this was likely to be sinus tachycardia with ischemia, ongoing ischemia, and therefore repetition of ECG when the rate settles is very important. Seeing a rhythm strip as discussed is very important. You can see that this seems to be regular in the 12 lead, but if you see the rhythm strip, it is irregularly irregular, suggesting this as atrial fibrillation. So the reward of taking a good long rhythm strip is there to diagnose arrhythmia, especially in the elderly. Even if you take a rhythm strip, long strip, initial aberrancy is seen and then it becomes narrow complex, suggesting this to be an aberrant conduction as compared to a tachycardia. So therefore, it's very easy if you have a tachycardia ongoing with a broad as well as narrow complex, which suggests the patient to have a SVT with aberrancy. Sometimes carotid sinus massage can cause VA dissociation and AV dissociation. So if you have a flutter with broad complex, the ventricular rate will decrease and you can see flutter waves, suggesting this tachycardia to be an SVT with aberrancy initially, or the retrograde VA dissociation can show it as seen in prior ECGs, suggesting it to be a ventricular arrhythmia. Lastly, when you have a 12 lead ECG and you have a broad complex regular rhythm and the patient is stable, you spend time to apply the algorithm. So what are the two algorithms which are discussed? The commonly used is a Brugada algorithm, which has 4 components. The first is, if you have an absence of an RS complex in all precordial leads, it suggests it to be a ventricular tachycardia. This primarily means concordance pattern, either negative or positive. If not, then you go to the next step, which suggests that R to S interval, if it is more than 100 milliseconds in any one of the precordial leads, it suggests it to be a ventricular tachycardia. This is primarily based on the fact that if it is a aberrancy through a bundle branch, the initial part is always fast. In a ventricular tachycardia which arises from the myocardium, the initial part will be slow and the later half will be more faster, and therefore the initial slur, if it is present, ventricular tachycardia is more likely. If it is absent, then you go to the third step whether atrioventricular dissociation is present, and if it is present in the presence of P waves which are lesser than QRS complexes, capture or fusion beats, then it is likely to be ventricular tachycardia. If it is absent, then you can go for a morphological criteria in which we have prior discussed. Presence of atypical bundle branch block is likely to have a ventricular tachycardia, and absence of atypical bundle branch block likely to be SVT with aberrancy. A simpler algorithm is as discussed, where the first thing that you see is for AV dissociation. If it is present, then it is VT. Then you go on to a next step if it is absent, to see whether initial R is present in AVR. As discussed, if you have a northwest axis, it is likely to be VT only. Then the third step, QRS morphology, if it is unlike bundle branch block or not. If it is unlike, then VT is diagnosed. And lastly, you see for the initial slur versus later slur. If the initial slur is more, then VT is more likely. If the later slur is more, SVT is more likely. So, as in this example, if you see, it's a regular complex. If you apply Brugada algorithm, the RS complexes are present. You go to the next step. Then you see for initial R to last S nadir. If it is more than 100, it is VT. Here it is less than 100, and it is likely. You have to go to the next step to see for presence of AV dissociation. AV dissociation is not seen in the form of less P waves or capture or fusion beats. You go to the next step. Typical or atypical bundle branch block. This looks like a typical left bundle branch block, and therefore it is likely to be SVT with aberrancy. In this broad complex RBBB, if you apply the algorithm, it's a initial. If you see that absence of RS complexes, the RS is there, so you go to the next step. From the initial R to the terminal S, as in V6, you can see it is more than 100 milliseconds. Though features of AV dissociation is absent, there is an atypical bundle branch block. The initial R is more than the later half, and therefore suggests to be a ventricular tachycardia according to the Brugada algorithm. How to differentiate VT from antegrade pre-excitation, and that we can see if you have a concordant pattern. So if you have a negative concordant pattern, it is certainly a ventricular tachycardia. If you have a positive concordant pattern but you have a QR complex, it is likely to be a ventricular tachycardia. If you don't have a QR complex, but if you see that the AV relationship is different from 1 to 1, it is likely to be a VT. But if it is equal to 1 to 1, and then you see in sinus rhythm that there is a pre-excitation, it is likely to be a SVT, antidromic tachycardia. So example of this would be, you have a positive R in V1, atypical bundle branch block. Now you need to differentiate between antidromic versus VT. You see that there is no QS pattern or QR pattern, and you see that there is 1-to-1 conduction, no AV dissociation, and in baseline ECG you see that there is presence of pre-excitation similar to that of the tachycardia. It is likely to be a antidromic pre-excited tachycardia. Are there specific ECG patterns? Yes, specific ECG patterns of idiopathic monomorphic VTs like fascicular VT, RVOT, LVOT and others are there. Bundle branch re-entrant VT is there. Mime fiber tachycardia and EIV are there, which we can discuss. RBBB, relatively narrow complex with left axis deviation in a structural normal heart, young patient should suggest fascicular VT. A patient who has a LBBB with inferior axis 2-3 AVF positive and 1 and AVL and AVR negative suggests it to be a outflow tract ventricular tachycardia, RV outflow. If you have a positive in V1 It suggests to be a left ventricular outflow tract tachycardia. A tachycardia which is similar to that of a sinus rhythm and a baseline trifascicular block, as you can see here, RBBB PR prolongation with left axis deviation, suggests more likely to be a ventricular tachycardia if you have presence of AV dissociation. If no AV dissociation is seen, it can be SVT with aberrancy also. Atriofascicular tachycardia presents with the LBBB with left axis deviation tachycardia, relatively narrowish, and it is with structurally normal heart most of the times. AIVR, especially in ischemia, results in a slow ventricular rhythm with dissociation, and as you can see here, there may be STT changes even in the beats of ventricular rhythm. Obviously, this resolves when the ischemia is gone. What about irregular broad rhythm? And the differentials would be ventricular fibrillation, torsates, polymorphic VT, uncommon to see monomorphic VT with irregularity, and lastly being atrial fibrillation, WPW, aberrancy. Artifacts can be also resulting in irregular broad rhythm. So VF to get on a 12 lead ECG is sometimes luck, or you have to be immediately cardioverting such patients without taking a 12 lead ECG. What you see commonly is a torsates, a shift around the axis. This is a commonly seen with long QT. Polymorphic VT with idiopathic ventricular tachycardias, there is no long QT. There are R1T PVCs which can initiate this. What we see commonly is atrial fibrillation with aberrancy through a bundle branch, where you have an initial which is very sharp, later very slurred, or AF with WPW as an irregular arrhythmia. Most of these AF with WPW aberrancy have a predominantly monomorphic rhythm. Of note would be an artifact in such patients which can be on Holter or even a 12 lead ECG, which may cause trouble and misdiagnosis. What you have to see is certain leads may show that there is a inside, there may be QRS complexes, as in this, or in a 12 lead you can see that most of them have a broad complex rhythm, but one lead shows a regular rhythm, and therefore these should be artifacts. Lastly, channelopathies like long QT, Brugada, CPVT, early repolarization syndrome, they have typical ECG on sinus rhythm like sinus bradycardia, QT long and T-wave alternance in long QT syndrome, or a QT short with atrial fibrillation and ventricular arrhythmia in baseline sinus rhythm ECG, or a Brugada showing ST elevation in V1, V2. In bidirectional VT, the baseline may be normal, but the classical bidirectional VT is likelihood of CPVT or digoxin toxicity. If you have an ERS, early repolarization, especially in the inferior leads, then it is possible that this patient may be a case of early repolarization syndrome. Pacemaker mediated rhythm, with many patients having pacemakers, you can have sinus tachycardia with paced rhythm causing a broad complex rhythm, which is normal. A sense V pace, the pacemaker can get the ECG rate up to 130. There can be pacemaker mediated tachycardia at the upper tracking rate of 120-130, that is programmed without a P wave seen, and this can cause incessant tachycardia and symptoms, and the pacemaker can be programmed accordingly. If you have atrial tachycardia also, which can be conducted at fast rates, it can be a cause of arrhythmia. So in summary, you have a broad complex tachycardia. It has to be considered as VT unless proved otherwise, especially in the presence of structural heart disease. A 12 lead ECG should be done if the patient is stable. You apply the algorithms to differentiate. If still doubt is there, treat as VT. Remember special situations. Refer or discuss if you are not clear. Thank you.